So we will start with the AIDS disease or the HIV infection that leads to AIDS disease. So what is this disease? First of all, we will go through the epidemiological triad of AIDS. So agent, host and environment, right? So what is the agent of AIDS? The human immunodeficiency virus, or previously known as human T cell lymphotrophic virus 3, HTLV3. That was its old name. Nowadays it is known by HIV virus. There are two types, HIV1 and HIV2. So the virus is a RNA virus, right? It is a RNA virus. What it does? The virus replicates in actively dividing T4 helper cells and uniquely destroys them. What does it do? It attacks the lymphocyte. Which lymphocyte? T4 helper lymphocytes. They enter into it and then replicate it in the process of destroying those T4 cells. So what happens? As a result, the immunity, the T4 immunity of a infected person is lowered severely. Where is this virus? If you want to detect the virus, where is it found? Or if you want to avoid being infected by it, then which part of the body should you avoid? So, HIV virus is found in greatest concentration in blood, semen and CSF. It is found but in lower concentrations in tears, saliva, breast milk, urine and cervical and vaginal secretions. So usually for detection of HIV virus, we do blood test. Everyone settle down fast. So it's a RNA virus. As you can see, there is a enzyme attached to this RNA. What is that? Reverse transcriptase enzyme. Usually what happens? If there is a DNA virus, it is transcribed to RNA and then the virus starts working. Usually in case of DNA virus. In RNA virus, what is there? Once it enters into the body, the reverse transcriptase enzyme activates. It creates DNA and that DNA then replicates into other viruses and then the cell is destroyed, the virus replicates in that way. Okay? And as you can see, in the envelope of the virus, there are several proteins, glycoproteins. Glycoprotein 120, then there is protein P24, P18. All these help in attaching the virus to the T4 helper cells. Host of AIDS, mostly prevalent in reproductive age groups, found in reproductive age groups, that is 20 to 49 years. The gender in which it is more prevalent, it depends on the region where the HIV virus is found. If it is in North America, Europe, Australia, it is found in mostly men. And in Africa, the sex ratio is equal. Okay? Even in Asia also, it is tallying with mostly men, the population, the HIV population. So what are the high risk groups where this HIV virus can be spread more? People having multiple sexual partners, who are having anal intercourse, men having sex with men, that is MSM and sex workers, intravenous drug users, transfusion recipients of blood and blood products, who are at the risk. Usually nowadays what happens is, when you are donating blood, it is checked whether it has any viral antigens or not. If it is there, then the blood is rejected. But sometimes it can be missed and you can seldom find reports that while blood transfusion, the patient contracted HIV. Some reports are still there nowadays. So there is always a risk. And then hemophiliacs and clients of STD have increased risk of contracting HIV. So what are the modes of transmission of this AIDS or HIV? That is unprotected sexual intercourse with an infected partner. There can be vertical transmission, means mother to child transmission. Do not talk. Unprotected sexual intercourse with an infected partner, there can be vertical transmission from mother to child. How it is transmitted from mother to child? In utero, within the uterus it can be transmitted. During the delivery, that is vaginal delivery, it can be transmitted. And while feeding breast milk also it can be transmitted. And then injection drug use. Rare, this thing is rare, infected blood or blood products. In that way also it can be spread. But the most chances of spread through each of these mode of transmission, as you can see, whether if there is a transfusion with blood products with HIV in them, there is a 95% chance that the person will have HIV infection. Highest risk of developing HIV is through transfusion of blood and blood products. It is the highest. Then needle perinatal transmission, the MTCT, 20 to 25% chance is there through vertical transmission. Then comes the intravenous. Okay, it is around I think 0.4%, 0.2 to 0.4% there is needle sharing, it can be there, and less than 0.1% to 0.01% it is through sexual intercourse. So the risk of contracting HIV is in this order: transfusion of blood and blood products, then MTCT, okay, then comes the needle sharing, and finally the unprotected sexual intercourse with infected partner. So these are the three major modes of transmission of the HIV infection. So incubation period, if a person gets the infection, when will it produce symptoms, right? So as you can see, it can take up to 10 years for the infection to develop. So agent infects the host. Now in the middle there is an asymptomatic period. At this time there is no symptom of the patient. It is called the silent period because of the reluctance or inability to test or inform partner. For example, if the person has not tested for HIV in that silent period, then the person might not be detected and there is no symptom, so the person is not knowing that he or she has this HIV infection. But it is communicable. Through all the three modes of transmission, if it is there, the person can transmit the disease to another person. Okay? And finally, when the disease develops, it is called AIDS. That is acquired immunodeficiency syndrome. Acquired immunodeficiency syndrome. So, who will develop the clinical disease remains uncertain. Possibly 10 to 30% will develop AIDS. Majority will never develop the disease, the AIDS disease. They will have the HIV virus in their blood, will not have the AIDS disease. But up to 30% will develop AIDS in the future. Another 25 to 30% will develop AIDS related complex. What is AIDS related complex? AIDS is basically when you have detected that your CD4 count is low, you have very reduced immunity. Okay? But what is AIDS related complex? AIDS related complex is when you have the AIDS with opportunistic infections. During this period, you are prone to contracting many opportunistic infections from Pseudomonas like Kaposi sarcoma, etc., etc. So many diseases are there which we will see in the later slides. That together with AIDS is called the AIDS related complex. However, it is estimated that 75% of those infected with HIV will develop AIDS at the end of 10 years. So, case definition for AIDS surveillance. Now, as a public health official, when you are surveying through the population, how will you define the person who is having AIDS? How will you define the person having AIDS? So, it should be an adult or adolescent more than 12 years of age, considered to have AIDS if at least two of the following major signs are present in combination with at least one of the minor signs. What are the major signs? Weight loss more than equal to 10% of body weight, chronic diarrhea for more than 1 month, and or prolonged fever for more than 1 month, intermittent or constant. At least two major signs are there and one of the minor signs are there, that is persistent cough for more than 1 month. Persistent cough for more than 1 month is not a minor sign considered here if the patient is already affected with TB. If the patient does not have TB, then it can be considered a minor sign. Others are generalized pruritic dermatitis, herpes zoster infection history, candidiasis history, herpes simplex infection, generalized lymphadenopathy and all these things. The presence of either generalized Kaposi sarcoma or cryptococcal meningitis is sufficient for the diagnosis of AIDS for surveillance purpose. Now, if a person you have detected, he has Kaposi sarcoma or cryptococcal meningitis, then for sure they can be brought under the AIDS definition, because these are exclusively like opportunistic infections that happens in AIDS patients only. So, if you find this in a patient, that means the person most probably has AIDS. You can bring them under the definition. This is for adult or adolescent. In case of a child, what happens? The definition is similar to this, only 2 major signs and 2 minor signs. The definition then changes to 2 major signs plus 2 minor signs. That is the difference between the definition for adult and definition for pediatric population. Then there is the expanded WHO case definition for AIDS surveillance. It is almost similar to the normal definition that is followed, but for the purpose of surveillance under WHO, it is loss of more than 10% body weight or cachexia with diarrhea, fever or both for at least 1 month, cryptococcal meningitis, pulmonary extrapulmonary TB, Kaposi's sarcoma, neurological impairment, esophageal candidiasis, then life-threatening disease of episodes of pneumonia and invasive cervical cancer. At least one or more of the following should be present, with, of course, a test for HIV antibody gives a positive result. So nowadays screening is very common for HIV. So the person has HIV screening positive and he has one or more of these symptoms, then under WHO definition you can tell that the person has AIDS or HIV infection. So accordingly, once you bring them under the definition of AIDS, you have to categorize them at what stage of the disease they are in, right? At what stage of the disease they are in, you have to categorize. So there are again 2 types of clinical staging systems. You can classify them according to their pathological characteristics, that is initial infective phase, then asymptomatic carrier phase, then their age-related complex, and finally they are developing AIDS. Or you can do the WHO clinical staging system for HIV infection and HIV related disease. So this is there in the book. It is very extensive list of 4 categories. You don't need to know very much about it. I will show you a diagram later. That from Park you will read and you will automatically understand which diseases happen in the primary phases of infection and which diseases happen in the very worst stages of AIDS infection. Okay. So according to that, the severity of the category is there. It is this diagram in Park. Okay. The opportunistic infections. In the left, that is the y axis, there is the absolute CD4 lymphocytic count. Means the CD4 T4 helper cells, the count. And these are the diseases. So if around 500 cells per microliter is there, that is it has not gone under 200. Okay. There was earlier a cutoff for AIDS definition that the CD4 count should be less than 200, then only we can define it as AIDS. Nowadays that definition has been scrapped, and no matter what, if any of the test is positive and the patient has any one of the symptoms, you start the ART or AIDS treatment. You do not look for CD4, wait for CD4 count. Okay. But if you want to know which infections can take hold of that person, it depends on the immunity level. So if it is a little bit better, then bacterial infections, TB, herpes simplex, herpes zoster, vaginal candidiasis, hairy leukoplakia and Kaposi's sarcoma can occur. If the status of CD4 lymphocyte count is again around 200 or below, there can be pneumocystosis, toxoplasmosis, cryptococcosis, coccidiomycosis and cryptosporidosis. And if it is very low, then disseminated MAC infection, histoplasmosis, CMV, retinitis, CNS lymphoma. So all these diseases are there in the severity, according to the severity of the AIDS disease or the CD4 count, these opportunistic infections can take place. At least remember these, the infections that can take place at a higher CD4 level. That is herpes simplex, herpes zoster, TB, bacterial infection, candidiasis, Kaposi's sarcoma, pneumocystis, all these diseases, pseudomonas infection, all these diseases names. If someone asks you what the opportunistic infection in HIV AIDS, Okay, then you should be able to tell all of these. Very common ones at least you'll be able to tell, 7, 8. Okay. So now we have crossed the definition, pathological and everything, or the criteria of defining AIDS. Now, how will you know that the AIDS has spread in your population and under your watch? What type of epidemic has occurred? There are 3 types of HIV epidemics that can take place, and it is there in all parts of the world in some form or the other. There can be low level HIV epidemics, there can be concentrated HIV epidemics, and there is a generalized HIV epidemic. So how do you define, categorize between these 3? You firstly see the high risk groups, how much it has spread in the high risk groups and how much it has spread in the general population. You see these 2 criteria. How do you account for the general population? You take a proxy for the general population, that is pregnant women. Pregnant women ke proxy niye tader moddhe, because they are always having HIV screening, right? They are HIV screened during the pregnancy ANC checkup. So you see the prevalence of HIV in them, and you see the prevalence of HIV in the high risk groups who are having themselves tested very often. So in the low level epidemics, what happens? Prevalence has not spread to more than 5% in any subpopulation or high risk groups. It is usually confined, but the disease happens more to higher risk behavior groups, that is sex workers, drug infection or drug injection, sorry, it should be injection, and men having sex with men, and etc. So in the high risk groups, the prevalence is more, but it is not more than 5%. So it is a low level epidemic. Concentrated means it is more than 5% in the high risk groups, but less than 1% in the pregnant women in urban area. So it is not that much prevalent in the general population. It is highly prevalent in the high risk groups, so that is concentrated epidemic. And what is a generalized epidemic? That firmly established in the general population and prevalence is consistently more than 1% among pregnant women in urban areas. So these are the 3 types of HIV epidemics that can occur. Now certain terms that you need to be familiarized with, you do not need to read these figures, just see the ones highlighted in red, that is, there is one term called PLHIV. PLHIV short form can come. What is that? People living with HIV. People living with HIV. That includes the incidence plus the prevalent cases, the new cases and the old cases, that is people living with HIV. So recently UNAID did a study and they found that there are 38, this is global parameters, 38 million people were living with HIV currently, and 81% of them knew their HIV status. 81% of them, knowing about your own status of HIV is also very important. So among those 38 million, 81% of them knew their HIV status and the rest did not know that they were living with HIV, okay? And certain people, 1.7 million, became newly infected with HIV in that year only. This is HIV AIDS graph in India. As you can see, it has been mapped throughout the years. What is this type of diagram called? Firstly tell. A type of diagram ka ki bole? Among the bars and the pie chart, the graphical representation of data, a diagram ta ki bole? Skewed na, normal distribution type jante chahiye. Ami jante chi diagram ta ki bole? Throughout the years mapping kora hoyeche case numbers. A type of diagram ke ki bole? Kevol line diagram. Line diagram. Whenever it never touches the 0 mark, okay, the curve will never touch the 0 mark, and it is seen for cases, prevalent incident, or whatever you track the number of cases throughout a period of time or throughout the years. So that is called a line diagram, okay. So here what you can see, throughout 1990, you are plotting the number of HIV incidents. It peaked around at 1998, 1997, 1998 it had peaked, the number of new cases, and then it again declined, and it has been last traced back to 2019. Okay. So there was a kind of HIV epidemic in India back in 1998. The number of cases rose dramatically. Again, you see the incidence of HIV, new HIV infections. Okay. Now, since that peak in 1998, new HIV infections have been reduced by 40%. New HIV infections have reduced by 40%. And for AIDS-related deaths, the deaths caused due to AIDS is called AIDS-related death. Okay, it had peaked in 2004, and it has been reduced now by 60%. But still in 2019, around 6,90,000 people died from AIDS-related illnesses worldwide. Okay. Again, as you can see in other stats, the 81% of people living with HIV knew their HIV status in 2019, and among the people who knew that they had HIV, 82% of them were accessing treatment, and among those people accessing treatment, 88% had been virally suppressed. That means their HIV count has lowered. Okay, means they have been turned into lowered or negative. Okay, it can happen. Just because the viral load has been lowered in you doesn't mean that the virus is completely absent from your system. Okay. So why am I showing you these percentages? Because there is a concept, a short note that can come, that is 90-90-90 for HIV. So what does this 90-90-90 mean? That 90% of the people should be aware of their HIV status, of which 90% should be on HIV treatment, of which 90% should be virally suppressed. So this is the standard that was being achieved, trying to achieve by 2020, I think. By 2020, this was the target. By 2019, though, that was the stats. That is, 81% knew of the status, of which 82% were on treatment, of which 88% were virally suppressed. Okay. So all over among 81% they knew their status. So overall among all the people living with HIV, 67% were on treatment, and among all the people living with HIV, 59% were virally suppressed. So these are overall stats. That is the last known spatial analysis in 2020, done in 2020. Okay, that was the evaluation of the, after any program or any scheme that you do a program evaluation and monitoring, right? So this is the evaluation result, that what has been achieved. What has been achieved. Now coming to TB HIV co-infection. This is very important. It can also come as a short note, because TB is the leading cause of death among people living with HIV. Okay, people dying from HIV, TB is the leading cause of death. So, in 2018, an estimated 10 million people developed TB disease, approximately 9% of whom were living with HIV. Okay. So, it is estimated that 44% of people living with HIV and TB are unaware of their co-infection and are therefore not receiving care. So, this is a very serious case. So, once you detect TB and HIV in a single person, what you do? First of all, when you detect a TB in a patient, you do the other viral markers. You see whether there is HIV or not, and vice versa. If you detect HIV in someone, you detect if he or she has TB or not. Now, if you detect co-infection, then when treating people with HIV and TB, ATT should be started first. First start the anti-tubercular treatment, then followed by ART as soon as possible, ideally within 2 weeks to 2 months. And in case of disseminated infection, you start between 4 weeks to I think 4 months tops, I think. Okay. So when treating people with HIV or tuberculosis, ATT should be started first and then followed by ART between 2 weeks to 2 months after starting ATT. And if you want to risk the development of TB in HIV patients, you give isoniazid preventive therapy and ART together. So they can reduce the risk of developing TB among the PLHIV up to 97%. So once you have a patient detected with HIV, but he or she doesn't have TB yet, you start isoniazid preventive therapy to prevent the development of TB in that patient. Okay, because that contracting TB will increase the likelihood of mortality by much more. So the estimated adult HIV prevalence trend has been declining in India since the epidemic peak in the year 2000 and has been stabilizing. The estimate of 2019 was 0.22%. Means this is the HIV prevalence. 0.22% of the people of the population are having HIV. Okay, are people living with HIV. And as you can see, over the years it has been decreasing. In each of the high risk groups also, it has been decreasing. That is in 2003, 2006, 2017, over the years it has been traced. And in each of the high risk groups, the prevalence is decreasing. So these are the high risk groups. So if someone asks you what are the high risk groups of the HIV, injecting drug users, transgenders, men having sex with men, female sex workers, truckers, migrants, and women attending antenatal clinics. These are all high risk groups. So how do you detect HIV? There are certain indirect tests and direct tests. Indirect tests means serological tests and direct tests means antigen tests. So serological tests are rapid tests, that is kit based test. Okay. Another is ELISA, which has high sensitivity, and Western blot, which has high specificity. Means rapid tests also have sensitivity, yes, high sensitivity, but not as high as ELISA. Okay. Means it is able to detect the true positives much more, but Western blot has high specificity, means it is able to find out who does not have HIV much more accurately. And others are antigen detection methods like P24 antigen capture test. The P24, as you remember, is on the protein that is on the envelope of the virus. So once you detect that, you detect the antigen. Or the polymerase chain reaction known as PCR. That by that also you can detect the HIV virus. Another thing that is also seen is absolute CD4 lymphocyte count, most widely used predictor for HIV progression. Now if a patient has HIV and you have put them on ART treatment and you are following them with time, you check the CD4 count whether it is increasing or not. So with that you can estimate whether the treatment is having any good effect or not, or the treatment is working or not. Risk of progression to an AIDS opportunistic infection or malignancy is high with CD4 less than 200 cells per picoliter. So less than 200 means that the patient has high risk of developing the opportunistic infections. But it is again used nowadays for only prediction, predictor or prognostic methods, not diagnosis. Just for prognosis whether the patient is improving or declining. Okay. So what is the algorithm? In HIV, you know that in screening there are two types of multiple screening methods, that is serial testing and parallel testing. Okay. In serial testing, what you do one test, then you do, depending on the result of that first test, you do the second test. And in parallel testing, you do two tests side by side. So in serial testing, what you do, if both of the tests come positive, then you only, if both of the tests come positive, then only you can detect that or declare that the patient has that disease or that positive test. But in parallel testing, only one of the tests needs to come true to declare it as a positive test. So here in HIV, we do the serial testing. You take the blood sample, you do the first test, usually ELISA. Okay, you do the ELISA. If it is non-reactive, it is negative. Okay, and it is reactive, you do the second test, that is Western blot test. So what you do, Western blot, as I said, it is it has increased specificity, so it will decrease the false positives. It will decrease the false positives. Okay, so among the person who are detected positive in the first, that is ELISA or any kit test, now the person who has been falsely diagnosed as positive will be weeded out by the Western blot test because it has high specificity. Then if it comes positive, then you term the patient, okay, now you have HIV disease or AIDS. So both the tests need to come positive for the patient to be declared as a positive HIV patient. So how to control AIDS? There are 4 basic methods, just remember the points. Firstly, you do the prevention. You promote education for all the high risk groups. Combination HIV prevention, that is you give or counsel them that certain contraceptive methods in combination can be used to prevent the transmission of HIV. Even if someone has HIV, he can prevent the transmission by the combination contraceptive methods like male and female condoms. Then again you can do the needle and syringe programs, the opioid substitution therapy with methadone, and the voluntary male medical circumcision. So all these methods are there that if used in combination can reduce the transmission of HIV. And prevention of blood-borne HIV transmission, all blood should be screened for HIV 1 and 2 before transfusion, and transmission of infection to hemophiliacs can be reduced by introducing heat treatment of factors of 8 and 9. So in any case, for hemophiliacs and for patients receiving blood transfusion, the blood needs to be screened whether it has any HIV virus or not. So this is prevention. Other prevention, what is there? Internal condoms, penile circumcision, as I can say, pre-exposure prophylaxis, use of sterile needles and syringes in everywhere. Then C-sections for HIV positive patients, because in the vaginal delivery there is a chance of transmission mother to child. So you do C-section for those patients. And not breastfeeding HIV positive. If the patient is HIV positive, if the mother is HIV positive, this is one of the few scenarios where you tell not to breastfeed. Otherwise, breastfeeding is always a benefit, greater benefit. But in case of HIV mothers, you tell them not to breastfeed the baby. And that's how you stop the transmission from mother to child. Now, all this, whatever I have told you, these prevention methods and everything, all this can be told at the, or you can acquire, or you can know about at the ICTC, that is Integrated Counseling and Testing Center. Integrated Counseling and Testing Center. In certain hospitals, there is some ART center where they receive only the drugs. But nowadays, what is happening? There is also an ICTC clinic which has an ART clinic attached with it. What happens at ICTC clinic, that the patient goes, they are counseled about the HIV infection and we need to screen for this test. They do the screening, the results are kept confidential whether positive or negative. If positive, they are guided towards further treatment, given ART. If negative, then they are counseled about how to prevent the contraction or transmission of HIV. So all this from the point of contact to the ultimate treatment, discharge or the counseling of the patient, this ICTC center is very vital in that part. So ICTC is integrated counseling and testing. That's why it is called integrated counseling is also happening and testing is also happening. So early detection, opportunistic screening of HIV and STDs, and provision of basic information, promoting behavioral change. If the person who is testing there is having some risky behavior, then they are counseled against it. Results and counseling purely confidential, reduction of fear and stigma, link with other HIV care, prevention and treatment services, and creating enabling environment, emotional support. So all these are provided at the ICTC. So at ICTC, what are they told? Usually about the transmission methods, that HIV spreads through sharing needles, drug injection, contaminated blood transfusion, mother to child transmission and protected sex. HIV is not spread through, that is to dispel the myths also, it is there told in the ICTC, that it is not spread through food, drinks, utensils and clothes. It is not spread through insect bites or kissing, touching or sharing bathroom or sharing food, okay. In those ways, the HIV is not spread. There are only 3-4 methods by which HIV virus is spread, and that needs to be ingrained in the patient who is coming to the ICTC center. Next, now prevention has occurred. Next comes the antiretroviral treatment, ART. Now HIV can be suppressed by treatment regimens composed of combination of 3 or more ART. The current ART does not cure HIV infection but highly suppress the viral replication or the viral load within the body and allows an individual's immune system recovery to strengthen. So it is not curative it is kind of allowing the patient to rebuild their immunity while suppressing the viral load. Now, before coming into this paragraph, I will show you the drugs and then mechanism of action first. That firstly you need to know what is the mechanism of action. That is, this is a virus. Okay, this is a virus. It first binds by the proteins to the membrane of our cell. So there, what you can give drugs, you can prevent the entry by giving certain drugs here. Okay, entry is prevented. Then when the virus is going inside, reverse transcriptase inhibitor, reverse transcriptase is there, and it is converting into viral DNA. So here you can use another type of drugs called reverse transcriptase inhibitors. So you prevent the conversion of the virus from RNA to DNA. Then it is integrated into the nucleus in this phase in our DNA. So you give another drug here of the group integrase strands transfer inhibitors. The strand is transferred into the nuclei of our cell. Okay. So here you can give another class of drug called integrase strands transfer inhibitors. Then after that the RNA is again produced. It is enveloped by a protein again. Assembly is happening, and then the virus is again taking a part of a membrane and then going out as a new viral particle. So in this way the virus is replicating. So here you can also give the protease inhibitors to prevent this assembly or replication, the final stage of replication of the virus. So in all these phases, there are entry inhibitors, here you can give fusion inhibitors, then reverse transcriptase inhibitors, integrase strands transfer inhibitors and protease inhibitors. In all these phases there are drugs you can give. So in combination you need to give these drugs. Now another thing is reverse transcriptase inhibitors can be of several types. There is a nucleoside reverse transcriptase inhibitors, there is a nucleotide reverse transcriptase inhibitors, and then there is a non-nucleoside analogues. So all these different types of drugs are there. So what are the examples of ART drugs in categories? Firstly, entry inhibitors, the fusion inhibitors is enfortumab, mavorixafor. Then nucleoside, NRTI is usually a full form for nucleoside reverse transcriptase inhibitors, but among them only one drug is there which is a nucleotide reverse transcriptase inhibitor, that is tenofovir. Others are all nucleoside reverse transcriptase inhibitors, that is zidovudine, stavudine, emtricitabine, abacavir, lamivudine. These are all drugs used in the regular regimen. Then there is a non-nucleoside reverse transcriptase inhibitors, that is efavirenz, nevirapine and etc. Protease inhibitors, ritonavir, darunavir, and the new group of drugs, that is integrase strands transfer inhibitors, that is dolutegravir and raltegravir. So in each of these categories you remember at least 1 to 2 names for each drug, okay, especially those which are used in the regimen. So what are used in the regimen? It is in your PARC book. For the adults and adolescents you give tenofovir, okay, TDF tenofovir, that is an NTRTI, and then NRTI, that is 3TC. What is that? Lamivudine and an integrase transfer inhibitor, that is dolutegravir. So you do this type of regimen, either a nucleotide plus nucleoside plus INSTI, or 2 NRTI and INSTI, or 2 NRTI and 1 NNRTI in pregnancy. So this is the regimen. Now you put drugs according to that. Okay. Remember the adults and the adolescent. Okay. All the other types of drugs are here. It will take some time for you to read about that, but the basic regimen is this. It has to be like this combination. Okay. This is the basic combination of the drug. So accordingly, it's the dolutegravir based or low efavirenz based treatment is for everyone living with HIV, including adults, pregnant women and adolescent girls, and childbearing potential children and people co-infected with TB. So either you give an INSTI at the end or an NNRTI at the end, along with 2 NRTIs. Okay, so that is the treatment for ART. You either give an INSTI or you give an NNRTI. Previously, when we were reading MBBS, we had protease inhibitors instead of this INSTI because INSTI was not approved yet. But nowadays, once INSTI has come, PI is not that much used nowadays. Okay. Now, treatment, there is, after treatment, there is the post-exposure prophylaxis. You do not have HIV, but you have been exposed to an HIV positive person. So, what you can do? This consists of first aid care, counseling and risk assessment, HIV testing, and then you have to take the drug for 28 days. And ideally, it should be started within 72 hours. So, either raltegravir or dolutegravir in combination with tenofovir and emtricitabine. So, this is the preferred regimen in healthy adults and adolescents for post-exposure prophylaxis. And prophylaxis for HIV related infections, cotrimoxazole is used. It is a fixed dose combination of two antimicrobial drugs and it is used as intervention for PLHIV to reduce the HIV related morbidity and mortality, that is to prevent the co-infections. You use the cotrimoxazole. Third method of control is specific prophylaxis. Okay. For specific prophylaxis means for the opportunistic infection, what they can use apart from ART, that is all these antibiotics are there, aerosolized pentamidine, dapsone. Then for Mycobacterium, it is rifabutin. And prophylaxis against prophylaxis or isoniazid preventive therapy can be used. Kaposi sarcoma, you can do interferon therapy, chemotherapy or radiation. For cytomegalovirus, it is ganciclovir. For cryptococcal meningitis, it is fluconazole. Same for the esophageal candidiasis or vaginal candidiasis. And for herpes simplex and herpes zoster, it is acyclovir or foscarnet. And finally, primary health care, it is for mother and child health screening, family planning and education. At the primary healthcare level, you can do such cross-cutting interventions to reduce the HIV burden and the new infections. This is how you can reduce the infections. We will take a 2-minute gap. I will again start at 2:50 and finish the rest of the STD. Now class, that is the sexually transmitted infections. So it is a group of communicable diseases that are predominantly spread through sexual contact and they are caused by a wide range of diseases from bacterial, viral, protozoal and ectoparasites, fungal and ectoparasites. Previously, STI classically had 5 venereal diseases like syphilis, gonorrhea, chancroid, lymphogranuloma venereum and donovanosis. It used to be these 5 that used to be defined under STI, but nowadays several other diseases are found to be transmitted through sexual contact and it has been all grouped under STI. So, what are some examples? Again, you need to remember at least 2 to 3 from each category, not more than that. So, under bacterial, there is a gonorrhea, Neisseria gonorrhoeae, chlamydia trachomatis, Shigella, Campylobacter, group B streptococcus. These can happen otherwise also, but these two usually are spread through sexual contact exclusively kind of. Neisseria gonorrhoeae, Chlamydia trachomatis. Then under viral, there is the herpes simplex virus, that is HSV1, HSV2. Mainly HSV2 more than HSV1 are transmitted by sexual contact. Then human herpes virus 5 or formerly known as cytomegalovirus, hepatitis B virus, human papilloma virus and HIV virus. Protozoal, it is the Entamoeba histolytica, Giardia lamblia and Trichomonas vaginalis. Fungal, it is Candida albicans and ectoparasite disease, Thyrus pubis and Sarcoptes cabi. So, 1-2 examples from each you need to remember from all the categories. So, there is bacterial, there is viral, there is protozoal, fungal and ectoparasites. So, what happens because of these STD diseases? What happens? If you have herpes and syphilis, there are drugs against this, obviously. It is herpes is viral and syphilis is leptospira syphilis. So, it is increasing the risk of HIV acquisition. Then there is mother to child transmission. What can happen in mother to child transmission of STIs? It can cause stillbirth, neonatal death, low birth weight and prematurity, sepsis, pneumonia, neonatal conjunctivitis and congenital deformities. So all these things can occur if STIs are transmitted from mother to child. Okay. Then in HPV infection, human papillomavirus infection, what can occur? Cervical cancer. And gonorrhea and chlamydia, it can cause pelvic inflammatory disease and infertility in women. So all these are the consequences of STDs. So these are all some pictures from the infection. What are the manifestations? In herpes simplex lesions, there are some cold sores like this. Okay. Then in secondary syphilitic lesions, it can be like ulcerative lesions on the hands and feet, etc. Then there are genital ulcers. Syphilis, there is genital ulcer, that is a shallow ulcer, that is it breaks down, the rash breaks down. Chancroid, it is a little bit deep and you can see as the herpes vesicles. It is, herpes are usually vesicular. Okay. In donovanosis, what occurs is there is an extensive lesion, there is a very wide lesion in donovanosis. Ulcer of vegetative type of lesion. So it is, and what happens is if you touch it, it will bleed. Okay. Painless beefy red ulcers with clean friable bases and distinct with rolled margin. And finally the HPV, that is human papillomavirus infection warts. These are all cauliflower like warts. Okay. So it will distinctly present as warts. And on the stain in the pap smear or the Papinicolau stain, you can find the stage of cervical neoplasia by seeing the size of the nucleus, right? So what to give in this STIs? What is the treatment for these STIs? In primary and secondary health centers, kits are given. Kits are given means depending on the symptoms of the patient. In the centers, what you do is the symptomatic management of the STIs. It is syndromic management or symptomatic management of the STI. So what is given? For urethral discharge, for cervical discharge, for painful scrotal swelling in these type of STIs, you give the grey kit. What does grey kit have? It has 1 gram azithromycin stat and tablet cefixime 400 milligram stat. This is the grey kit, that is the first kit. Second, for vaginal discharge, where you have very foul smelling vaginal discharge, that means there is a fungal infection in vaginal discharge. In that fungal infection, you give the green kit. Okay, 2 grams secnidazole and fluconazole 150 milligram. Then you, if there is a lesion, okay, there is a lesion and an ulcer formation, but it is not from herpes. It is not from herpes, but there is a ulcer. So in genital ulcer, single or multiple, painful or painless, if the person is not allergic to penicillin, then you give them penicillin, that is benzathine penicillin and azithromycin. If they are allergic to penicillin, you give doxycycline and azithromycin. So it is a white kit and a blue kit. It depends on whether the person is allergic to penicillin or not. In genital ulcer, non-herpetic. Once the genital ulcer is having herpes, that is from the herpes, that means it is a viral infection, it should be treated by antiviral like acyclovir. So it becomes a red kit. So tablet acyclovir 400 milligram TDS for thrice daily for 7 days. Okay. So till now we had the grey kit, the green kit, the white kit, blue kit and the red kit, right? Now comes the lower abdominal pain, that is in case of pelvic inflammatory diseases. You give tab cefixime, OD stat, then tablet metronidazole 400 milligram BD for 14 days and doxycycline again for 100 milligram BD for 14 days. So metronidazole and doxycycline you give, plus you give cefixime stat. So you give a combination of antifungal and antibacterial, right? And finally that is a yellow kit. And then inguinal bubo, it is a black kit is there for the bubo that is causing the STI. So tablet azithromycin 1 gram with doxycycline for 21 days. That is the treatment for inguinal bubo, that is the black kit. Apart from giving the treatment directly, again in these ICTC centers, you are counseling for safer sex practices and importance for taking complete treatment. treating the partner also, provide other contraceptive safe practices methods, and you have to follow up. Follow up after 7 days for all STI. That is at the 3rd day, 7th day, 14th day for lower abdominal pain, and for the 7th, 14th and 21st day for inguinal bubo, to see whether they are following up with the treatment or not. Otherwise the treatment won't work, the infection will persist. And consider immunization against hepatitis B. Okay, the person doesn't have hepatitis, consider immunization against hepatitis B. So these are all the syndromic management of STI. The heading for this whole diagram, the diagram is actually in totality one. The one diagram I have divided it into to fit into the PPT, but this whole diagram has a heading syndromic management of RTI STI. Again, for adolescents in the ARCH clinic or the Shiroka clinics, they practice Ornesha clinic, whatever you tell them to practice abstinence, delay the onset of sexual intercourse, use the barrier methods of contraception, have no more than one partner, then get vaccinated for HPV and report any other health problems. Now again, control of STDs, that is, previously you learned the control of AIDS, now you have to learn control of STDs. What is that? You firstly initiate the planning, that is how will you control STD in your area. You have to first plan for that. That is to define how will you define or bring patients of STD under your purview, establishing priorities, setting objectives and strategies to manage the cases. Now what are the intervention or the case management things that you can do to reduce the number of cases? Firstly, you do the case detection. How do you do the case detection? You first screen the population, especially high risk population for any STDs. Okay, then if they are positive, then you see what is the contact tracing is very important here. How many people have they come in contact tracing, and cluster testing. In any other clusters, if there is there for syndromes is there in another cluster of population, you do testing there. So in that way you detect the cases first, you accumulate the cases first, and then you hold them and do the treatment first to last. You do not let them disappear or let them drop out of your treatment. Epidemiological treatment or contact treatment. If contact is been there for the case, but the contact doesn't have any symptoms yet or doesn't have even the disease yet, still you do the epidemiological treatment or the preventive treatment so that the disease does not develop. Maybe the infection is there but the disease does not develop. So that the disease does not develop, you do the preventive treatment or the epidemiological treatment here. Then you recommend the personal prophylaxis with contraceptives and vaccines, and finally you give health education. What are the support components? STD clinics are there, ARCH clinics or Ornesha clinics are there. Laboratory services should be upgraded to detect all these different STDs. Okay. Primary healthcare and information system support should be there. That is, all these facilities should be at least available, basic should be available at all primary healthcare so that it is accessible to all the patients. And finally, social welfare schemes. And finally, the program, whatever you have done, you finally monitor and evaluate whether this can be improved upon or not, and then increase the case detection and then monitoring and treatment success rate of your strategy. So this is how you can control the STD spread in your population area. The health program that is related to this HIV and STDs is, it is not under NHM. This is the only program in India which is not under the National Health program, okay, not under the NHM. National Health Mission and under a active program name. It is under different program, that is, or organization, that is National AIDS Control Organization, NACO. NACO under a program ta ache. So what is the name of the program? It is basically standardly we say NACP, National AIDS Control Program. But now it has included the STD component as well. So National AIDS and STD Control Program, right now it is in phase 5. Before it is from 1992, it is phase 1, phase 2, and for 5 years, 6 years it has been there. Right now it is in phase 5. So this is the name of the program, National
three
AIDS and
things
STD Control
to be
Program,
presented here.
or
One
simply you
is the
can say
live
NACP,
program.
National AIDS Control
One
Program.
is the counseling and communication.
So
with
with the
patient.
emergence of the
And
HIV
third is the
epidemic in
important
India
discovery
only,
of
this
the-
program was brought.
This is the you
And
have come.
as per
enjoy
WHO
the
estimate, around
temple,
10% of all
enjoy
adults are infected with
together
curable
sit,
STI each year.
enjoy your life.
So what
And
has
this 5
happened
years
under
trip.
this NACP?
Thank you. Thank you.
Coordinates RTI and STD at all levels of healthcare. Free standardized RTI STI services provided through 1160 clinics situated at government healthcare facilities, and these clinics are also called Suraksha clinics. Okay, so this is the program for the diseases, AIDS and STI diseases.